Welcome to the deep dive. So today, I want you to just picture a person who is actively struggling with an alcohol problem, like really picture them.
Right. Yeah. What do they look like to you? Or, where are they?
Exactly. Because our culture has spent, well, decades really, painting this very specific, very stubborn picture for us.
Oh, absolutely. It's usually this image of someone whose life is like visibly falling apart.
Yeah, someone who has just simply run out of willpower. We've historically framed struggling with alcohol as a, I don't know, like a moral failure or a character defect.
Right. Or just this inability to hold things together like a responsible adult. The cultural narrative basically tells us that is a choice someone is actively making day after day.
Because they just lack the internal fortitude to stop.
Exactly. It implies this deep sense of weakness. And honestly, that pervasive stigma does a massive amount of invisible damage to the people who are actually suffering.
It really does. So we are tossing that antique narrative out the window today. The mission for this deep dive is to completely reframe how we understand alcohol use disorder, or, AUD.
And we have some incredibly illuminating excerpts today to help us do that.
Yes, we do. From a recovery guide published by Coping and Healing Counseling, CHC for short, this guide really drags the conversation out of the dark ages of moral judgment and, well, plants it firmly in the reality of modern medical science.
It really does. It's a complete paradigm shift.
Okay, let's unpack this.
Yeah.
We often think of addiction like a light switch. You flip it up and it's glaringly on. You have a capital P problem,
Right.
and then you flip it down and it's entirely off and you're perfectly fine. But the source material paints a completely different, much more nuanced picture of what is actually happening.
It does. And moving away from that binary light switch analogy
Yeah.
is really the absolute first step in understanding the modern medical approach here. The medical community's understanding of addiction has evolved drastically over the last few decades, and this CHC guide, it serves as this vital blueprint.
A blueprint for both the what and the why, right?
Exactly. It shows us the internal mechanisms of AUD and the structural pathways to treating it. It shifts the whole paradigm away from shame and toward, highly accessible, comprehensive healthcare.
So to understand that medical reality, we really have to look at how the medical field actually defines alcohol use disorder today. Because if we were saying it's not a character flaw, well, we need to understand what makes it a structured health condition.
Right. And the diagnostic standard used by medical and mental health professionals across the board is the DSM-5,
The big manual.
the big manual, yeah. When a professional uses this, they are not looking for a lapse in morality. They are evaluating a medical condition that's defined by 11 specific criteria.
Wait, 11. That is a lot more granular than a doctor just asking, like, hey, do you think you drink too much?
Oh, absolutely. It forces a very thorough examination of both behavior and biology. The guide lists some key examples that illustrate how these criteria actually manifest in real life.
Like what?
Well, for instance, drinking more or for a much longer period than you originally intended, or making repeated unsuccessful attempts to cut down or stop entirely.
Wow, okay. That specific criterion completely shatters the willpower myth right there.
It really does, yeah.
Because, if a person is actively trying to cut down and they are failing repeatedly, they clearly have the desire to stop. The willpower is there. Something else is just overriding it.
Exactly. What is overriding it is this complex combination of physiological and psychological hurdles.
Right.
The DSM-5 criteria also include things like experiencing strong, intrusive cravings, and it includes developing a tolerance.
Which means you just need more to get the same buzz.
Right. On a biological level, your liver enzymes are adapting and your brain's receptors are actually downregulating. So you physically require more alcohol to achieve the exact same effect.
That's wild. And then there's withdrawal, right?
Yeah, withdrawal is huge. That's where your nervous system essentially rebounds into hyperdrive when the depressive effects of the alcohol wear off.
Okay, so it's a massive constellation of behaviors and physical reactions.
It is. And the criteria also heavily weight the social and physical impact, like, continued drinking despite it causing clear, quantifiable harm to your health, your career, or your relationships.
And the guide points out something crucial here. This is not a pass or fail test. It is staged by severity.
Yes, exactly. It's a spectrum. If you meet just 2 to 3 of those 11 criteria, that is clinically considered mild AUD.
Okay.
4 to 5 criteria is moderate. And then 6 or more moves you into the severe classification.
I love that they break it down that way because viewing it on a spectrum fundamentally changes the intervention strategy. Like, you don't have to hit 6 criteria to have a valid medical concern.
No, not at all.
It makes me think of the check engine light on a car's dashboard.
Oh, that's a great analogy.
Yeah. Right. Like when that little orange engine icon pops up, it does not mean your car is currently exploding on the highway.
Hopefully not.
Yeah, hopefully not. It doesn't mean the engine block is completely cracked in half. It is an early escalating warning sign.
Right.
So meeting 2 or 3 of those DSM-5 criteria is like that first flicker of the light. It's telling you that something under the hood needs serious maintenance before you end up stranded.
And just like a check engine light, you don't just use a piece of black tape to cover it up and keep driving.
Right, but that's what people do, right?
It is. That is exactly what people do when they ignore mild AUD. They wait for absolute rock bottom.
Yeah.
So for you listening, consider how understanding this graded scale from mild to severe might reframe how you view your own habits or even the behaviors of a loved one.
It makes the prospect of seeking help much less intimidating, I think.
Exactly. Recognizing mild AUD as a subtle warning sign rather than like a catastrophic personal failure is huge.
Yeah.
You are allowed to ask a professional to take a look under the hood long before the system breaks down.
Okay, so if the DSM-5 has 11 very clear, highly documented check engine lights, the logical question becomes, why do doctors keep missing them?
Yeah, that's the big question.
Because the source material makes a specific point of highlighting that AUD is frequently completely overlooked in routine primary care settings.
It goes undetected because alcohol use disorder is, honestly, a master of disguise.
The master of disguise, how so?
Well, when someone walks into a primary care physician's office, they almost never sit on the exam table and announce, "Hi, I meet 4 criteria of the DSM-5 for alcohol use disorder."
Right, yeah, nobody talks like that. They are coming in because they feel awful, but they don't necessarily know the root cause. Or, maybe they are subconsciously hiding it.
Exactly. So they present with secondary physical or mental complaints. The guide notes that AUD typically surfaces in the doctor's office disguised as like severe insomnia
Oh, wow.
or chronic hypertension, gastrointestinal complaints like acid reflux, or persistent anxiety and low mood.
Okay, but let me play devil's advocate here regarding the doctors for a second. A standard primary care visit is what, maybe 15 minutes long?
If you're lucky, yeah.
Right. So if a patient comes in complaining of burning stomach pain, or they report they haven't slept more than 3 hours a night for a month, the doctor's immediate job is to fix that acute pain. They are going to write a prescription for an antacid or a sleep aid.
Naturally.
So how is a time-crunched doctor supposed to connect the dots from a stomachache to alcohol intake without coming across as, I don't know, incredibly accusatory or intrusive?
What's fascinating here is that you've just articulated a massive systemic flaw in how modern healthcare is structured.
Really?
Yeah. Medical professionals are often conditioned and, frankly, pressured by time constraints to treat the presenting symptom rather than investigate the underlying cause.
Just put a Band-Aid on it.
Exactly. If a patient presents with elevated blood pressure, the immediate clinical reflex is to prescribe an antihypertensive medication.
Right, and that little pill fixes the number on the blood pressure cuff, absolutely.
But it does absolutely nothing to address the fact that drinking a six-pack every single night is what's driving the vascular system into overdrive in the first place.
Yeah, the symptom is suppressed, but the disease just keeps progressing.
Exactly. And this is exactly why the CHC guide strongly advocates for the structural integration of brief, validated screening tools in all primary care settings.
They specifically point to a tool called the IUITC, right?
Yes, the IUITC.
So what is the mechanism behind that? How does a piece of paper change that 15-minute doctor visit?
Well, IUIT stands for the Alcohol Use Disorders Identification Test, with a C indicating it's the concise, modified version. It's a very short, highly structured questionnaire.
Okay.
And the brilliance of it really lies in its universal application. By making this screening a standard, mandatory part of a medical intake, just like stepping on the scale or checking your heart rate, it completely removes the interpersonal judgment.
Oh, that makes sense, because the doctor isn't singling the patient out because they suspect something.
Exactly. They're simply running a routine diagnostic algorithm for everybody. This neutralizes the stigma, and it often uncovers the true root cause of that stubborn insomnia or anxiety before the doctor just throws another pill at the symptom.
Which is huge. And unmasking AUD in the doctor's office brings us to a much deeper realization, I think. Because when we strip away the disguise of anxiety or low mood, we find that AUD almost never exists in a sterile vacuum.
No, it rarely does. The co-occurrence of AUD with other mental health conditions is a major cornerstone of the CHC guide.
Yeah, they really emphasize that.
AUD frequently walks hand in hand with other deeply rooted psychological issues. The text explicitly highlights anxiety, depression, and trauma as the primary co-occurring conditions.
And that shifts the internal monologue, right? From I just drink too much to something much more profound.
Absolutely.
It becomes, I drink too much because my nervous system has been stuck in a state of hypervigilant fight or flight from a past trauma, and alcohol is the only chemical I have found that turns the volume down.
Right. Or, I drink because it provides a temporary numbing effect for severe, untreated depression. Alcohol is essentially functioning as a highly accessible, rapid-acting, but ultimately deeply destructive coping mechanism.
It's self-medication.
Exactly. It's self-medication.
Yeah.
And if a treatment program only focuses on detoxing the patient and removing the alcohol, but completely ignores the underlying PTSD or the clinical depression, they've done a massive disservice to that patient.
Because you've just stripped away their only coping mechanism, however flawed it was.
Yes.
And you've left them completely unprotected against the raw trauma that drove the drinking in the first place. That sounds like a recipe for disaster.
It is. That vulnerability leads almost inevitably to relapse. The brain demands relief from the psychological pain.
Of course.
So the guide stresses it, treating both the AUD and the co-occurring mental health conditions simultaneously is the only proven method for achieving what they call durable recovery.
Durable recovery, I like that phrase.
Yeah, they are not looking for a temporary pause in drinking. They are aiming for a lasting, sustainable restructuring of a person's health.
But the word durable implies something that can withstand the elements, right? Something sturdy. How do you actually build that?
Well, the guide lays out a very specific combination of treatments. It starts with psychosocial care.
Right. And they list things like cognitive behavioral therapy, motivational interviewing, and contingency management. But I got to push back on the terminology here for a second.
Oh, go for it.
Motivational interviewing, contingency management, these sound like corporate HR buzzwords. Like, they sound like techniques used to increase quarterly sales, not help a human being heal from trauma. What do these practices actually look like in a real therapy session?
There's a fair point. The clinical nomenclature can sound pretty cold, but the actual execution of these therapies is incredibly compassionate and it's highly structured.
Okay, break that down for me.
Let's look at the mechanics. CBT, or cognitive behavioral therapy, is about investigating the mechanics of a person's thoughts. It helps a patient identify the very specific, often subconscious thought patterns that trigger their desire to drink.
Okay.
So, if a stressful meeting at work automatically triggers the thought, I need a drink to survive this evening, CBT teaches practical, real-time skills to intercept that thought before it becomes an action.
Oh, I see. So you are actively rewiring the brain's automatic neural pathways. You're putting a speed bump between the trigger and the reaction.
Precisely. You're giving them a moment to choose a different path. Then we have motivational interviewing.
The HR buzzword.
Right. But think about the old school idea of an intervention, where a group of people lectures the patient about why they're ruining their life and forces them into treatment.
Right, lots of yelling, lots of tears.
Exactly. And we know scientifically that external shaming rarely produces durable change.
Makes sense.
Motivational interviewing flips that dynamic. The therapist acts as a collaborative partner, not this authority figure dictating orders. They ask strategic, open-ended questions designed to help the patient discover and articulate their own internal motivations for wanting to change.
Wow. Okay, so it respects the patient's autonomy. It pulls the desire to heal from the inside out rather than trying to, hammer it in from the outside.
Yes, it is profoundly empowering. And finally, we have contingency management. This is a behavioral mechanism based on positive reinforcement.
Okay, how does that work?
It provides tangible, immediate rewards for documented positive behaviors, such as providing a negative breathalyzer test or consistently attending therapy sessions,
Oh, okay.
because AUD profoundly hijacks the brain's dopamine reward system. Contingency management helps retrain that system to recognize and value healthy achievements again.
Got it. So that covers the behavioral and psychological rewiring. But the guide's blueprint does not stop at therapy, does it?
No, it doesn't.
It insists on pairing this psychosocial care with FDA-approved medications.
Yes, the pharmacological aspect is vital. The guide highlights medications like naltrexone, acamprosate, and disulfiram. And a common misconception here is that medical treatment for addiction just substitutes one addictive substance for another.
Right, that's what a lot of people think.
But that is entirely false here.
How do they actually work in the body then, if it's not a substitute?
They work on fundamentally different neurological mechanisms. Take naltrexone, for example. It actually blocks the endorphin receptors in the brain.
Okay.
So if a person takes naltrexone and then slips up and has a drink, they do not experience that characteristic euphoric buzz.
Wait, really?
Really? The alcohol might make them clumsy or tired, but the chemical reward is completely gone. It systematically breaks the brain's association between alcohol and pleasure.
That is fascinating.
And then acamprosate, on the other hand, works to stabilize the chemical balance in the brain that gets severely disrupted by long-term alcohol abuse. So it helps reduce the physical distress of maintaining sobriety.
So you are basically attacking the disorder from every conceivable angle. You combine the behavioral rewiring of CBT, the internal drive of motivational interviewing, the neurological blockade of medications like naltrexone, and you are simultaneously treating the underlying trauma or depression.
Exactly. When you look at the larger medical picture, the text's assertion is pretty undeniable. When you combine evidence-based therapy with targeted medical support, durable recovery is not a pipe dream. It's not a statistical anomaly. It is a highly achievable medical outcome.
But see, here's the thing. We have this incredible, proven blueprint for dual diagnosis treatment. But there is a massive chasm between knowing how to build the building and actually getting it built.
Oh, absolutely.
For the vast majority of people, the primary barrier to durable recovery is not a lack of desire, and it isn't a mystery about what treatments work. The barrier is the sheer logistical nightmare of trying to access that care.
You're completely right. Access is historically the single greatest bottleneck in mental health and addiction medicine. Just think about the friction involved for a normal person.
Oh, it's immense.
You have geographic distance, especially for people in rural healthcare deserts. You have months-long wait lists just to see a specialist.
Prohibitive out-of-pocket costs, too.
Yes, and a lack of providers who are actually trained in treating complex co-occurring disorders. These aren't just minor inconveniences. They are massive structural walls standing between a patient and the treatment they desperately need.
Which is exactly why we have to examine models that are actively trying to dismantle those walls. And the CHC guide serves as a fascinating case study in modern healthcare infrastructure.
It really does.
Coping and Healing Counseling has designed a delivery system specifically engineered to remove that friction. Let's look at the composition of their clinical team first, because the human element of the infrastructure really matters here.
It's vital. The guide details a diverse, culturally competent team of over 15 licensed therapists.
And we are talking about highly specialized professionals, right?
Yes, licensed clinical social workers, licensed professional counselors, and licensed marriage and family therapists.
But why does that specific multidisciplinary makeup matter so much to the patient?
Because treating co-occurring disorders requires a wide net of expertise. One size definitely does not fit all. Furthermore, cultural competence is not just a buzzword. It is a clinical necessity.
How so?
Well, therapy requires immense vulnerability. If a patient does not feel seen and understood within the context of their own cultural background, the therapeutic alliance simply will not form, and treatment will fail.
That makes a lot of sense. And they also aren't limiting their scope to just adults struggling with alcohol, which I found interesting.
Right.
The infrastructure supports individual, couples, family, and teen therapy for ages 13 and up, along with life coaching. They specifically target those root causes we explored earlier: anxiety, depression, trauma, PTSD, grief, and chronic stress.
But the true structural innovation of the CHC model is the delivery method itself.
The telehealth aspect.
Exactly. They operate a 100% telehealth practice that is fully HIPAA compliant. The guide notes they serve all 159 counties in the state of Georgia.
See, operating entirely via telehealth fundamentally changes the mechanics of seeking help. Think about a runner's starting blocks.
Great.
For someone grappling with AUD, motivation does not usually arrive in a steady, reliable stream. It comes in very narrow, fleeting windows.
So true.
So if a person feels motivated to get help on a Tuesday morning, but the nearest clinic is an hour drive away and they have to take half a day off work, arrange childcare, and sit in a stigmatizing waiting room, that window of motivation closes.
The friction is just way too high.
Exactly. But by placing the clinic on a laptop in their bedroom or, on a smartphone in their parked car during a lunch break, you move the starting blocks right to the runner's feet. You capture the motivation before it evaporates.
It's the ultimate removal of geographical friction. And they also integrate the medical side by providing warm referrals to prescribers when those FDA-approved medications are clinically indicated.
Well, that's incredibly helpful.
Yeah, it ensures that the diagnosis and the medical management are handled by licensed professionals, all without the patient having to navigate a labyrinth of different office buildings.
Now, removing the geographic friction is brilliant, but we have to address the financial friction.
Always the biggest hurdle.
Historically, comprehensive dual diagnosis programs are notorious for being financially ruinous for the average family.
Financial friction is often the final insurmountable wall for people. And this is where CHC's infrastructure model really proves its commitment to actual accessibility.
Let's hear the numbers.
The economic details provided in the source material are vital here. By utilizing a telehealth model, they drastically reduce overhead, and they translate that directly into patient access. For patients on Medicaid, there is a $0 copay.
Wow. A $0 copay effectively eliminates the economic barrier for the most vulnerable populations.
Yes.
The populations who statistically suffer the highest rates of untreated co-occurring disorders.
It fundamentally changes the economic reality of healthcare. And for patients utilizing commercial insurance plans, the guide lists major networks like Aetna, Cigna, Blue Cross Blue Shield, United Healthcare, and Humana. The out-of-pocket costs are dramatically reduced,
What are we talking usually?
typically ranging from just $10 to $40 per session. It frames comprehensive care not as a luxury for the wealthy, but as an affordable, integrated part of normal life.
And for anyone listening who wants to look into that, the contact info in the guide is phone number 404-832-0102, or you can go to cheektherapy.com or email support@cheektherapy.com.
It's incredible to see a model actually doing the work.
It proves that the structural barriers can actually be broken. So as we bring this deep dive to a close, let's synthesize exactly what we've uncovered from this material.
We've covered a lot.
We really have. We started by dismantling that toxic, outdated myth of willpower, looking instead at the hard medical reality of the DSM-5 spectrum. We saw how crucial it is to recognize those early check engine lights before a crisis hits.
And we examine the mechanisms of how AUD disguises itself in primary care, manifesting as common physical ailments like insomnia or stomach issues, and why systemic tools like the AUD-ITC are so vital for seeing past the disguise.
We laid out the complex blueprint for durable recovery. We explored the mechanisms behind why we must treat the alcohol reliance simultaneously with the underlying trauma using a powerful combination of behavioral rewiring and targeted neurological medications.
Right.
And finally, we looked at how telehealth models like CHC are actively destroying the geographic and financial walls that keep people from that life-saving care.
And for you, the listener, absorbing this specific knowledge changes your position in the healthcare landscape.
Absolutely.
It equips you to be an informed, proactive advocate for yourself and the people you love. When you understand that AUD is a medical condition driven by profound underlying mechanisms, and that comprehensive recovery is both scientifically achievable and structurally accessible, well, it removes the shame from the equation entirely.
It brings the whole conversation out of the shadows. I want to leave you with one final thought to mull over today, building on everything we've discussed. We spent a lot of time talking about how incredibly stealthy AUD can be,
Yeah.
how it successfully disguises itself in the doctor's office as everyday insomnia or chronic stress or unyielding stomach pain. It raises a really profound question about how we interact with our own biology. What if we started viewing our persistent, unexplained physical ailments not just as isolated mechanical glitches to be quickly medicated away, but as profound, urgent invitations from our bodies to finally examine our deepest coping mechanisms?